Hello, dear students. Hope you all are safe at home in this pandemic. As we have discussed about anemia, its classification, thalassemias in previous lectures, today we will discuss about nutritional anemia. And in nutritional anemia, today we will stress only upon iron deficiency anemia. I request you all who have not subscribed to my channel, please subscribe my channel to keep in touch with me. As such, anemia we have already discussed. Anemia is defined as condition where the hemoglobin concentration or the hematocrit value of an individual is lower than the level considered normal for the person's age and sex. Whichever may be the person's age and sex, according to the age and sex, if level is less than it is known as anemia. And WHO have given some values, cutoff values, below which we consider that particular age person as anemic. Like in late infancy, up to 5 years, it is less than 11. Then 5 to 11 years, it is 11.5, less than 11.5. Then 12 to 14 years, it is less than 12. In adult males, it is less than 13. And in females, non-pregnant, it is 12 and less than 12. And in pregnant females, it is less than 11 for the cutoff value for anemia. If we discuss about prevalence, around 40% of the world population is having some degree of anemia, which indicates that more than 2 billion people are anemic. Thus, we can say that anemia is one of the most commonest chronic condition worldwide, mainly in children, adolescents, and females. It is more prevalent in developing nations, like in developing nations, preschool children, around 42% of the preschool children are anemic, while school-going children, up to 53% of the school-going children are anemic. In comparison to developed nations have very less anemia. I will discuss about prevalence in India. Then in National Family Health Survey third, which was conducted during 2006-7, the total of the anemia in age group of 6 to 36 or 35 months age children, it is around 79, which later on get reduced. And in 2015 demographic health survey of India, childhood anemia, which is not up to 35 months, but whole of the childhood anemia, there is around 58.5% of the children who are anemic in India. One of the multicentric study of India in 1998 indicates high prevalence of anemia, mainly in age groups of 10 to 18. That is, adolescents age group have high incidence of anemia. Around 50% of the adolescents in India are anemic. If we talk about causes of nutritional anemia, the most prominent cause is iron deficiency. It is one of the commonest cause of anemia as such, and one of the commonest cause of nutritional anemia. Other causes of nutritional anemia include deficiency of B12 vitamin folic acid, which causes megaloblastic anemia. It also causes a significant number of cases in India, because most of the Indian population is vegetarian, and the sources of B12 is mainly non-vegetarian. Then some other factors may also contribute to the nutritional anemia, and they are vitamin A deficiency, thiamine, riboflavin, pyridoxine, even vitamin C, vitamin E, and trace elements like copper and zinc. They can also contribute to the nutritional anemias. If we talk about causes of iron deficiency anemia, then most common cause of iron deficiency anemia is inadequate intake of iron or reduced availability of the dietary iron. As such, in India, we are vegetarian, and a vegetarian diet have less available iron. Other factors may be decreased absorption due to various factors which reduce absorption of the iron from the diet. Increased need of iron, like in childhood period where there is active or acute growth, there is a large increase in mass, as well as we should increase according to the increase in weight or height. That's why the iron need in that particular age groups is more, and food usually does not provide that much iron. That's why these age groups, like in adolescence, these age groups, or like in late infancy to toddler age group, they are having acute phases of growth wherein iron requirement is much high than provided by diet, vegetarian diet. That's why these age groups are having more incidence or prevalence of the iron deficiency anemia. Then other causes may be chronic blood loss due to bone infestation. Bone infestation is also an important cause of iron deficiency anemia in poor country like India. Then non-specific causes may be there, like chronic infections. If we assess role of iron, then 70% of the iron in human body is in the form of hemoglobin, and we all know that hemoglobin is oxygen carrying protein in blood. Then other remaining 30% iron is present in the form either myoglobin, which is present in muscles. Then various enzymes have iron as its part, like cytochrome C or cytochrome 450, various catalyses, cyclooxygenases, and so many enzymes have iron as a component. Some of the other enzymes have iron dependent processes. Iron acts as a catalyst in their activity, like an ADP dehydrogenase, which is one of the most important enzyme for energy release. Then aldehyde oxygenase, tyrosine hydroxylase, and so on. If we talk about storage of the iron, then in children, usually 70 milligram per kg of the iron is present as storage. In male, it is around 4 grams, and in females, it is around 3 grams of the total iron is present in our body. What are the factors which determine the absorption of the iron? Some factors promote the absorption of iron, while other factors inhibit the absorption of iron. The factors which promote the absorption of iron are ascorbic acid, vitamin C. Vitamin C is one of the commonest factor or inducer of absorption of iron. Other are free HCl. If stomach does not secrete hydrochloride, then hydrochloric acid is not secreted by the stomach, then absorption of iron may be impaired. Then presence of sugar as well as amino acid in diet also promote the absorption of iron. Heme iron is good for absorption of the other type of iron. Meat, fish have heme iron. Then germination and fermentation of the food. Usually they will reduce various factors which are present in cereal, like phytates. Phytates are reduced by germination, and phytates are the factors which inhibit the iron absorption. So a germinated food will improve the absorption of iron present in that particular cereal or food. Factors which inhibit or absorption of iron, they are alkaline pH, less अगर pH होता है तो, then various antacids which will decrease the secretion of HCl, bran or starch, phytates in the cereal, or tannins in the tea and coffee. They will reduce absorption. They will inhibit absorption of the iron. Phosphates calcium present in various dairy products, then soya protein. Absorption promoters, if we use absorption promoters with the food or with the iron supplements, then they can enhance the absorption of iron up to 40%. If we take some fruits which have ascorbic acid or vitamin C in it with the food, then absorption of iron present in food will increase definitely. Then viability of iron, we all know that iron came from two sources. One is heme iron, that is iron from hemoglobin, and non-heme iron, which comes from vegetarian sources. The non-heme iron have very less viability in comparison to heme iron. Heme iron have 20 to 30% of the viability, while only 2 to 5% of the non-heme iron get absorbed. Another factor in viability is ferrous iron. Ferrous iron is better absorbed as compared to ferric iron. Wheat-based diet usually have very less absorption of iron, like 2% of the iron is absorbed, while rice-based diet, there is around 5 to 13% of the absorption of the iron present in that particular rice-based diet. Poor viability in cereal-based diet is the major cause. There may be iron present in various cereals or leafy vegetables which is being taken with cereals, but viability of this particular iron is very less, and very less part of this iron get absorbed, and that is the major cause of iron deficiency anemia, usually in vegetarians. While fish, meat, or poultry products have good source of heme iron, and its iron is more available. Calcium present in milk and cheese depresses iron absorption. That's why dairy products usually precipitate iron deficiency anemia. Excessive dairy products during weaning, breast milk से wean कर रहे हैं, and we are giving dairy products, we are giving only cow's milk, that usually will result in iron deficiency anemia. One, by reducing iron absorption from breast milk or other sources which is being given to that particular infant, and another is milk or cow's milk can produce micro hemorrhages from the large intestine. They are both result iron deficiency anemia. Then dietary sources, from where we can get iron. Green leafy vegetable, all know, jaggery, गुड़ से. Cereal, basically ragi जो है, have good iron. Then in fruits or dry fruits, it is dates, almonds, various nuts. Sprouts germination will promote absorption of iron. Then non-vegetarian sources are the best sources of iron, and in that also liver is a very good source of iron. Risk factor in infancy, why infants get more chances of iron deficiency anemia. Infants who are born to the mother which have iron deficiency, they will get less iron during fetal life. If mother have moderate to severe anemia, then fetal iron store will be compromised. Mild anemic mother will not compromise the fetal iron storage, and maternal iron deficiency during lactation will also result in less iron in breast milk, and that will result in less iron to the uh, baby feeding on that particular breast milk. Maternal iron deficiency is one of the factor. Another factors are breastfeeding beyond 6 months without introduction of the complementary feed, and complementary food is being introduced, but the food chosen is very poor in iron, or the iron viability of that particular food is poor. They all will result in iron deficiency anemia in infancy. Iron deficiency anemia is not only anemia, it have very deleterious effects on the various other parameters like mental growth, like immunity. and that will result in a poor school performance, recurrent infections, malnutrition. So, iron deficiency anemia will start a cascade of events which will ultimately result in malnutrition as well as poor school performance. And how this poor school performance is there, various studies have shown that person or the children who are having iron deficiency anemia usually have less IQ than uh, persons with normal HB. The iron deficiency even before producing anemia can impair various mental and motor development, lower IQ, poor concentration, poor attention, short attention spans and distractibility. Easily distract हो जाते हैं ऐसे बच्चे. And poor physical performance and endurance leads to poor motor skill and productivity. तो जो है lethargic होंगे, एक जगह बैठे रहेंगे, motor activity will be poor, and this reduced physical activity will affects their learning, because most of the learning in infancy or toddler age group or in preschool children is by exploration of the environment. And if the child is lethargic, is not having energy, then he will not explore the environment and his mental development will affect. These all factors cumulatively will result in poor school performance, and which will result in dropouts, and dropouts, poor education, poverty, poor awareness towards various health programs, poor supplementation of iron during pregnancy, and that will affect not only that particular person, but it will affect generations. That's why iron deficiency anemia is very important to treat. How we will approach the iron deficiency anemia for diagnosis? We will have history, physical examination, and various tests, and then after diagnosis, a proper management will result in cure of the iron deficiency anemia. In history, basically, the in children, the age of onset is 6 months to 36 months, and the basic cause of iron deficiency anemia in this particular age group is faulty feeding, not introducing complementary feeds timely, or introducing complementary feeds which are not rich in iron, or iron is not available in that particular food. That is the major cause of iron deficiency anemia in these children. Both the sexes are involved up to the adolescence. After adolescence, females are more involved because females have monthly blood loss, and that particular blood loss will result in iron deficiency anemia. In diet, lack of breastfeeding, because breast milk contains iron which is very much bioavailable than other milk. That's why lack of breastfeeding will result in iron deficiency anemia. Excess of animal milk, जिसकी हमने पहले बात करी कि cow's milk can have deleterious effect, because calcium present in cow's milk will impair the absorption of iron from other sources, and animal milk usually results in biliary atrophy, microhemorrhages from the intestines, which will further deteriorate the iron absorption, as well as there will be increased iron loss in the form of hemorrhage. Inadequate weaning food, predominantly vegetarian diet. This exclusive breastfeeding up to 6 months prevents anemia. That is very important. We should feed the infant up to 6 months only breast milk. Then history of pica. Pica is craving for mud or non-edibles like chalk, ice, cardboard, etc. So history of pica is very useful for iron deficiency anemia, diagnosis of iron deficiency anemia. Then there may be some time history of breath holding spells. Infections should also be ruled out, mainly one infestation like hookworm or roundworms or giardia. Symptoms of iron deficiency anemia as such are almost similar to the symptoms of any type of anemia. There will be irritability, loss of appetite, fatigue, shortness of breath, lethargy or lassitude, and weakness, cramps, failure to thrive, dyspnea on exertion. And if HB falls gradually, then these symptoms may not be start acutely. There may be insidious onset of these symptoms, and symptom may not be noticed till HB falls to very severe category, that is less than 5. In physical examination, we have discussed already in anemia that there will be pallor. Pallor we noticed in conjunctiva or tongue or palmar ridges. There may be puffiness, periorbital puffiness. There may be edema or hemic murmurs in the chest. Then tongue will be pale, walled and shining. There will be glossitis, basically flat, bald tongue. Loss of papilla will result in walled tongue. Angular stomatitis may be there. In nails, there is koilonychia or platinichia. Then in megaloblastic anemia, there may be hyperpigmentation of knuckles. And very rarely, there may be Plummer-Wilson syndrome, which have a triad of koilonychia, esophageal valves, which usually causes dysphagia, and splenomegaly. But it is very rare. This picture shows some of the clinical features like pallor in the conjunctiva, then koilonychia and thin nails, platinichia, then palmar ridges, normal palmar ridges, and pale palmar ridges. And then physical examination should also be done to exclude other causes of anemia like abnormal facie in hemolytic anemia, hemolytic facie, hepatosplenomegaly in thalassemia, lymphadenopathy in various infections, bony tenderness in leukemia, petechial hemorrhages or purpura in aplastic anemia or leukemia. Then recent weight loss will indicate towards malignancy. Skeletal changes, various bony changes may be present in Fanconi's anemia, where renal involvement can cause skeletal changes. In differential diagnosis, basically in iron deficiency anemia, differential diagnosis is with the anemia which causes microcytic hypochromic anemia, and the main causes of microcytic hypochromic anemia in pediatric age group are mainly lead पॉइजनिंग, पेंट से या इन चीज़ों से जो lead पॉइजनिंग हो सकती है बच्चों में. देन बीटा थैलेसीमिया ट्रेट, इसकी हमने थैलेसीमिया वाले लेक्चर में भी बात करी कि बीटा थैलेसीमिया ट्रेट में जो मेंडजर इंडेक्स है और चीज़ें देखते हैं हम, उसमें जो है दैट विल डिफरेंशिएट इट फ्रॉम आयरन डेफिशिएंसी एनीमिया. Then thalassemia major may initially be confused with iron deficiency anemia in early infancy or early part of the second half of the infancy. Then HBH disease, that is thalassemia, alpha thalassemia, category of alpha thalassemia. And then anemia of chronic disease may also sometimes produce symptoms like or clinical picture like iron deficiency anemia. In investigation, HB estimation, HB तो देखना ही है. Then in peripheral smear, RBC, that is RBCs will be hypochromic and microcytic hypochromic, and there may be anisocytosis, poikilocytosis may be there. MCV will be less than 80 FL Falcoliter. MCH mean corpuscular hemoglobin will be less than 27 picograms. Then MCSC will be less than 33%, and RDW, that is red cell distribution width, will be increased. It is normal in or less than 14 in thalassemias, and in iron deficiency anemia, RDW is increased. The two major points differentiating between thalassemia trait and iron deficiency anemia is RDW as well as Munsell index. This picture shows hypochromic and microcytic. This is compared with this cell the cell size is less, and the HB is also poor. There is more than 45% of the pallor in the center. Then other investigation which are important to diagnose iron deficiency anemia, it is serum ferritin. Serum ferritin less than 12 nanogram is very sensitive test for iron deficiency anemia, but serum ferritin in infections or inflammation may be increased, which may result in missing of the diagnosis of iron deficiency anemia. Serum iron, it varies with the time of the day. Usually morning have more iron while evening sample have less iron, but iron level less than 30 microgram per deciliter is indicative of iron deficiency anemia. Total iron binding capacity will increase. More than 350 or 400 microgram per deciliter indicates iron deficiency anemia. Then transferrin saturation is also very important. The transferrin protein which transfer or transport the iron, its saturation less than 12% in infants or less than 14% of in children indicates iron deficiency anemia. Free serum transferrin receptors of more than 9 milligram per liter is also indicative of iron deficiency anemia. Transferrin receptor will increase in iron deficiency anemia. Bone marrow usually is not being done to the diagnose iron deficiency anemia. Then diagnosis, as such, multiple indices or multiple positive finding will produce the diagnosis of iron deficiency anemia, and response to the iron therapy is also diagnostic for the iron deficiency anemia. There will be reticulocytosis in 7 to 10 days. There will be very good reticulocytosis. Reticulocytes will increase, and there will be HB increase from 4th day onwards, and this HB increase is usually 0.1 gram per deciliter. More HB increase is seen in children who are having severe anemia. And at field level, we can diagnose on the basis of pallor present in conjunctiva, tongue, or nail changes, can make the diagnosis of iron deficiency anemia. And this shows various stages of iron deficiency. Then treatment of iron deficiency anemia in HB below than 5 gram, that is very severe iron deficiency anemia. There is high risk of cardiac failure. These patients must be hospitalized, and if there is CCF, then they be managed with packed RBCs. And packed RBCs may be considered in other patients who are having HB less than 3 gram per deciliter but are stable, or patients who are having HB 4 gram per deciliter or less but are having infection, or very young children who are prone to CCF at this particular level of HB. They must be transfused with 2 to 3 ml of packed RBCs per kg at one time. Then for oral treatment, oral iron can be given in a dose of 3 to 6 milligram per kg per day in divided doses. And most common used salt are ferrous sulfate, which provides 20% of the elemental iron, gluconate 30%, and fumarate. These three salts are most commonly used. Other salts are also available commercially, but their efficacy is not well studied in children. There are some side effects as well with oral iron, and these side effects include mainly GIT side effects, which includes nausea, vomiting, diarrhea, or pain abdomen, or in some cases constipations. There may be discoloration of stool becomes blackish, and staining of tongue and teeth may be problematic. They become more dark or blackish brownish colored, and sometimes there may be true intolerance. Oral iron therapy, what are the basic points to be remembered for oral iron therapy? The dose, that is 3 to 6 milligram per kg per day. It can be given into 1 to 2 doses. More than this is unnecessary. If we are giving 10 milligram or 15 milligram per kg, then it is unnecessary. It will only add on the various side effects. Intolerance cause karega, but it will not increase iron absorption. Iron absorption maximum can be achieved by 6 up to the dose up to the 6 milligram per kg. And iron, if given empty stomach, HCl will make more iron absorption. But if it is not tolerated empty stomach, then it can be given with food. Duration, iron should be given 3 months after HB has normalized. Usually 2 to 3 months uh, is taken by various children to recover to their expected HB in severe cases, and further 3 months are required to replenish their stores. That's why uh, iron should be given at least 3 months after HB has been normalized. There are various drug schedules, daily as well as twice weekly or once weekly schedules. Then parenteral iron therapy. What are the indication for parenteral or IB or IM iron therapy? If there is severe intolerance of oral iron, or there is heavy GIT bleeding, or GIT bleeding is aggravated by oral iron, or preoperative iron can be given in urgent surgery. Surgery बहुत जल्दी करनी है, and oral iron takes time to increase HB, then parenteral iron therapy may be given. And if GIT have some problem, chronic diarrhea, small absorption syndromes, then parenteral iron should be preferred. There are various formulation. Previously, iron dextran was the most popular or most available formulation. Now, iron sucrose is one of the commonest preparation which is being given parenterally. To calculate the dose, there are two basic formulas. One is weight into HB deficit. How to calculate HB deficit? HB deficit is the expected HB. Say expected HB is 13, and actual HB by investigation it came out to be 7. Then deficit is 6. 13 minus 7, it is 6. So weight, say weight of the baby is 20 kg and deficit is 6 kg, then it came out to be 20 into 6 into almost 4. So it will came around 480 or 500 milligram. The other way is the weight of the child HB deficit into 2.5 plus the iron store. Iron store, how much of the iron store is required to replenish the iron stores, like 500 milligram maybe in children, or in adults it may be 1000 milligram. Then how the iron will respond, or iron how the body will respond to the iron. In 12 to 24 hours, there will be the replacement of enzymes, subjective improvement will be there, reduced irritability and increased appetite. And second day, there will be erythroid hypoplasia. If we assess bone marrow, then there will be erythroid hypoplasia. Third day onwards, there will be reticulocytosis, which can be accessible from peripheral from CBC. Then 4 to 20 days, there is increased HB level, 0.1 gram per deciliter. Each day it will increase by 0.1 gram per deciliter, and in 1 to 3 months there will be replenishing of stores. Sometimes the iron therapy may not respond, and what are the causes? If we give iron for 15 days and the child or the person is not responding, then possibilities may be there. There may be megaloblastic anemia, B12 deficiency may also be there, and we are not giving B12. There may be thalassemia or red cell aplasia, or we may have chosen wrong formulation, or dosage is not sufficient, or the patient may not be taking iron due to bad taste or staining of teeth or some other side effect. And sometimes we may not be treating the cause. There may be GIT bleeding, and we are giving iron, and this iron is resulting in more and more GIT bleeding, then there may not be a response, and there may be other causes as well. Then this was treatment part. Then how to prevent? Prevention is better than cure always. And for prevention, exclusive breastfeeding, increased intake of dietary items which have high bioavailable iron, supplementation of medical iron. We can give iron in particular age groups which are prone to iron deficiency anemia. We can supplement their food with some iron, or food fortification is another method for prevention and control of various infection, mainly parasitic infections. Uh, Promoting consumption of iron, increasing all the dietary foods which have high iron contents like green leafy vegetables, fruits, cereals, pulses, mainly sprouted, and jaggery. And if feasible, animal flesh or egg or poultry. Then green leafy vegetable must be added in weaning foods of infants. We should reduce consumption of tea so that tannins do not interfere with the absorption of iron. Uh, Kitchen garden for iron-rich foods. Then antenatal clinics to promote iron to the mother during antenatal period. Then supplementation may be given to some prone age groups, and in supplementation in 6 to 12 months we can give 10 milligram iron folic acid in syrup form. In 1 to 3 years, 20 milligram. 3 to 5 years we can give 20 milligram plus 100 microgram of folic acid. Then 5 to 10 years we can give 40 milligram, and in adolescent we can give up to 100 milligram of the uh, iron in at least for 100 days per year. गवर्नमेंट ने बहुत सारे जो है स्कूल प्रोग्राम्स में शुरू किया है आयरन सप्लीमेंटेशन कि एक पर्टिकुलर डेट को मंथली और वीकली जो है आयरन दिया जाता है, डिवॉर्मिंग की जाती है. Then a weekly or bi-weekly supply of iron can be given, and trials have shown that weekly supplementation of iron is as effective in older children when given under supervision. Then iron fortification of foods, we can supplement directly iron tablets, or we can fortify the food by various iron formulations like wheat flour or other cereals can be fortified. In many countries, food fortification has been found to be effective in reducing prevalence of anemia. And in India, double fortified salt, fortified with iodine and iron, have been found compatible with cooking, and iron deficiency anemia को prevent करता है. Then recommendation for prevention of nutritional anemia. The basic recommendations are that exclusive breastfeeding for 6 months. Then introduction of foods which are rich in iron as well as vitamin C, which enhance absorption of iron. Avoiding various foods or beverages which reduces the absorption of iron like tea, coffee, and supplementation of iron as well as folic acid B12 with counseling. This was all about iron deficiency anemia. If you have query, then you can ask me at my WhatsApp number. In next lecture, we will discuss about the second part of nutritional anemia, that is megaloblastic anemia caused by folic acid deficiency as well as B12 deficiency. I missed to add the slide of Ayurvedic part of iron deficiency anemia, but we can discuss it here. Iron deficiency anemia, if we want to compare आयुर्वेदिक एंटिटी, तो हम बात करते हैं कि पांडु जो है एनीमिया के कंपेरेबल डिजीज है, क्योंकि वहाँ पे वर्ण उन्होंने पांडु बोला। एंड आयरन डेफिशिएंसी एनीमिया की बात करें तो उसकी etiology या उसकी जो पैथोजेनेसिस है या उसके ट्रीटमेंट पार्ट को देखेंगे तो इट मोर रिजेंबल टू कफज पांडु। कफज पांडु में कफज आहार बिहार डेयरी प्रोडक्ट्स, मिल्क प्रोडक्ट्स यूजली विल इंक्रीज कफ एंड विल प्रोड्यूस पांडु। तो यहाँ पे आयरन डेफिशिएंसी एनीमिया में भी बच्चों में खासकर जो कफ का काल है या बच्चों में कफ ऐसे ही ज़्यादा रहता है, वहाँ पे प्रिवलेंस ज़्यादा है। उनके फूड्स में भी यूजली जो है मिल्क या इस तरह की चीज़ें देते हैं, तो आयरन डेफिशिएंसी एनीमिया होने के चांसेस बढ़ जाते हैं। ट्रीटमेंट देखेंगे तो जो आयरन डेफिशिएंसी एनीमिया को ट्रीट करते हैं, वी ट्रीट आयरन डेफिशिएंसी एनीमिया विद आयरन। और आयुर्वेद में बात करें तो कफज पांडु में जो चिकित्सा है वो मेनली लौह की है, लौह वसम है। लौह बेसिकली कफ शामक है, लेखन है। तो लौह आयुर्वेद में भी लौह वसम या हरित की, गौमूत्र हरित की कफज पांडु में वर्णित है। तो जो भी ट्रीटमेंट है वो बेसिकली जो आयरन डेफिशिएंसी एनीमिया को ट्रीट करने वाली है, कफज पांडु की चिकित्सा। तो अगर हम बात करें आयुर्वेद की तो कफज पांडु इज अ कंपेरेबल एंटिटी टू द iron deficiency anemia in modern science. This was all for today. Then we will discuss in next lecture about megaloblastic anemia. Thank you, one and all.